Okay, we're
Got
recording.
it going?
Yep.
Okay, well, welcome everyone. It's my pleasure to welcome you to WACCRA's educational lecture tonight. My name is Rick Baugh, and I'm the past president of WACCRA, and I'm glad to be here hosting you all. Let me give you a little bit of a background on WACCRA in case either you may not be familiar with it or may not. So let me spend a few slides on that. And the mission of WACCRA is to educate people, and tonight's a good example of that. Another example is our consumer guide for CCRCs in the state of Washington. A second part of our mission is to collaborate with other organizations. And an example of that has been fighting for some Medicare issues that saved CCRCs in the state a bundle of money, as they proposed a tax that would have cost in the neighborhood of about $250,000 at each CCRC that has skilled nursing. Another example is getting the budget for the long-term care ombuds in the state restored. They accidentally cut their budget. And last session, we had to get that restored. And the third one is to advocate for issues and rights of residents of the 23 CCRCs in the state of Washington. So that's a quick review. I don't want to spend a lot of time on that. If you want to get more information about WACCRA, you can go to our website. There's all kinds of information there. And we're in the season of membership drive. So if you are a member of WACCRA, you'll be hearing about it. And if you'd like to join WACCRA, you can go on our website and find a membership application there. But tonight I have the privilege of introducing Jim deMaine. Jim and I both live in Skyline, so I've had the great pleasure of getting to know him and his wife over the last couple of years. And as a background, Jim went to medical school at UPenn, and roughly the same time, his present wife moved from the Philippines to New York City to go to graduate school in nursing. You would expect that they probably met on the Metroliner or something like that, but in fact, they met in Afghanistan, of all places. Got married and moved to Seattle after spending a year in New York City, where Jim really focused on infectious diseases, which I guess comes in handy today, Jim, with all the activity in the world. And got more interested in pulmonary care and critical care at group health, where he spent the vast majority of his career. He's also in Skyline been very active in a variety of medical issues, and a prolific person that adds a lot to our CCRC blog. He posts all kinds of interesting articles on there that are they range from the informative to the hilarious. So, and he's also worked on a couple of medical issues in our CCRCs that's increased the quality of our life, and was instrumental in helping getting the defibrillator machines, emergency defibrillators, stationed around our CCRC. So Jim, with that introduction, I will stop sharing my screen and give you control of the screen, and you can take over from here. Oh, one other thing. If you have questions, Jim's quite willing to entertain those questions either as we go or at the end. I'll be monitoring those. So if you'd like to do a question, just type it in the chat, and I will monitor those questions as we go. So chat's usually at the bottom of the screen. If you click on that, you'll get a window that allows you to type in your question. And I'll keep my eyes peeled on that as we go. All yours, Jim.
Okay, well, thank you so much, Rick, and thank you all for coming. I see we have 55 people here, probably, hopefully scattered from around the state. And thank you for coming. This is a difficult subject and difficult time of year and difficult time for our nation. It just so happens that a year ago tomorrow, January 20th, the very first case of COVID-19 was diagnosed in Washington State, the very first in the country. And then today, as you know, if you watch the evening news, we are now having more than 400,000 deaths in our country. So it's been a very, very difficult time. Death has been a subject that has been kind of thrust upon us. But in my own career, I ultimately specialized in pulmonary and critical care. Critical care wasn't even a specialty when I started out. In fact, when I was in medical school, we didn't even have intensive care units. So I've watched the evolution and had to acquire more training and more board certification during my career in order to stay legitimate. It was kind of an interesting career. But my patients taught me a lot over the years about the end of life. And I've, in retirement, been speaking in the community and blogging about advanced care planning, the choices we have toward the end of life, and then how to make those choices known to others. And I'll start with a story. The book I've written, Facing Death, Finding Dignity, Hope, and Healing at the End, really is a book of stories from my personal experience. But tonight, rather than just read from the book or tell stories, I'm going to go through more of the talk that I give about advanced care planning, and then I'll have some references to the book as I go along. But let me share my screen here, make sure we can do this. And there we are. I hope you can see this. Let me just do one other thing here quickly. Okay. A patient came into my office early on in my career, and as you might imagine, since I specialized in pulmonary medicine, I saw a lot of patients with emphysema and lung cancer. But this particular fellow had advancing emphysema and recurrent infections, recurrent hospitalizations. He was on oxygen, he was on maximal medication, but he was kind of a crusty guy. We kind of got to be friends over several years of managing difficult hospitalizations. He'd always make it out and get back home to his waterfront place, was out on Bainbridge Island. He said in the clinic one day, "Hey doc, I want to take you out to lunch." And I liked the guy, wouldn't mind going out to lunch, but he was a super salesman, and I was afraid he was actually going to try to sell me something. But we did go nearby the hospital, and he sat down after some small talk. He said, "Doc, I want to talk to you about dying. I know I'm near the end, but I'm just suffering. I feel like a fish out of water every time I get one of these flare-ups. I'm gasping. My quality of life is suffering. I can't even bend over and do clams anymore. I just want help at the end." And I said, "Well, what do you mean?" He said, "I really want help at the end because I know it's near." And I said, "Well, I'm not Dr. Kevorkian, but there are things we can do. And the main one is to use morphine, a very common and old drug that we all know about." And he said, "Well, what in the world would morphine do for me?" I said, "Well, it would relax you. It would help your shortness of breath. It would make you sleepy, and it would give you a sense of euphoria and take away any pain. And it could be used in doses that could make you comfortable." He said, "Well, that's what I'd want." I said, "Well, you know, there is a downside to that, Larry. If you take this medication, it can actually speed up your death by a matter of hours or even days." And he said, "Well, that's not a concern to me. I just want to be comfortable at the end." So we talked some more, and I made tentative agreement with him about that. And I said, "Talk it over with your sons." He had two sons, one an attorney and one a veterinarian. And I said, "You know, get back to me. Tell me what your sons think." So he did, and everybody was pretty much on board. And so not much happened for a few months. He was kind of going along okay, but then one evening, right after dinner, so right in the middle of the Christmas season, unfortunately, I got a call from the emergency room saying Larry was there. He was really blue. He was short of breath, and they wanted to put him in the intensive care unit. And I said, well, I'm not sure he wants to go there. Let me come in and see him. So in those days, actually, we did, not work in shifts. We were more pretty much on call. So I went in and saw Larry, and he looked me in the eye and he said, remember what we talked about. So I kind of reviewed the plan to admit him not to the ICU, but to a medical unit. And so he got up to the medical unit, and fortunately, there were two very senior nurses there. And they were on board with the plan to just titrate his symptoms with small intermittent doses of IV morphine to get him comfortable. The nurses were very happy with that plan because they just hate to do CPR and heroic care with somebody that's right at the end and not respecting their wishes. So we did that. By that time, the sons were there and they were in agreement. So there wasn't any conflict. And he died peacefully at about 3 a.m. And later I got a beautiful letter from his sons saying, Dad, got his wishes were listened to, and if he could come back now, he would shake your hand. But I was thinking, what would have happened to Larry if I was out of town, or if one of the sons disagreed, or if maybe he wasn't strong enough to voice his own wishes, and none of us knew. So that got me thinking about, there's a lot of people like Larry, a lot of us that are aging, and we all acquire some degree of illness, and what are our wishes, and how do we know about those? What are our options for care? So that's why I have put together this kind of talk, and there's no clear right or wrong answers, but I want to just walk you through some of the options. So here's an article that was in the Atlantic 4 years ago, which really struck my eye. I am certainly not this guy on a skateboard. Notice how terrified he looks and how scrawny his legs are. It looks to me like he's ready for a hip fracture, but it's making the point that we are aging. And the major article in this issue is what living to 100 will mean for you in society. And more of us, particularly people being born today, a lot of them will live to be 100, even on average. Another article in this issue that really struck me was by Ezekiel Emanuel, the brother of Rahm Emanuel. Ezekiel's an oncologist and professor of ethics at Penn Medical School. And he wrote this article on why I hope to die at 75. It was probably somewhat tongue-in-cheek, but he was really saying that his life was complete and he wasn't even sure he'd take an antibiotic even after he's 75. So in my book, I have an article rebutting this view of aging. I think it was somewhat tongue-in-cheek, but I think there was some ageism for sure that crept into that article, which really annoyed me. So William Saroyan said, everybody's got to die, but I've always believed an exception would be made in my case. And, I think that that's true. I think denial is fine. We go about our day-to-day lives and we know death is out there, but in order to enjoy the day and to enjoy our loved ones and at the theater or the opera or whatever you enjoy, we've got to be able to put that on the back burner. But at some point, or at least intermittently, we have to be more practical and think about it. And part of the reason for this is that more than 50% of us are unable to make our own healthcare decisions during the days or weeks prior to death. We're just too sick to participate. And I was at the dinner table last year when we could do that with a 92-year-old woman, and this subject kind of came up. And I said, well, if your heart stopped or you got really, really sick, would you want shocks and CPR? And she said, well, I'll think about that when the time comes. And I said, you better think about that now and talk to your loved ones and family. So we got into advanced care planning and kind of set up this course at Group Health, now Kaiser, to invite everybody 65 and over to come and talk about advanced care planning. It was totally elective. They would come in and get the forms and be encouraged to go back and talk to their doctors. And lay people can run this, so social workers can run this type of education. I know a number of hospitals like Virginia Mason offer these things. Some funeral services even offer advanced care planning, like People's Memorial has a course called Getting Your Ducks in a Row. And there's an organization statewide called Honoring Choices, which is bringing out this kind of education. So it is coming out to the public. We have more and more opportunity to prepare. But part of advanced care planning is clarifying your beliefs. And I think the most important thing any of us can do is choose a spokesperson and have that spokesperson really understand you and understand your wishes. Because as a doctor at the bedside, when you're very sick, we're going to turn to your loved ones, and hopefully the one that is your durable power of attorney for healthcare. And I'm sure most of you have these forms. You're all in CCRCs, you're all planners. So I may be bringing Coles to Newcastle here, but I hope some of this is a review for you and make you think and make sure you are prepared. We need to understand life-sustaining treatments. So what are they, and what are the odds that they're going to benefit me? It's kind of, we're all signed up for CPR. We're all signed up for life-saving treatment. If we go down at Nordstrom and we don't have another way of saying no CPR, we're going to have everything done. Somebody's going to bare our chest, do 100 compressions a minute, and if an AED or defibrillator is nearby, try to shock your heart back to normal rhythm. So what are the upside? What's the downside? It's kind of like going into surgery. You want informed consent, but do we really have informed consent for this life-sustaining treatment? We need to think about that ahead of time. So I will talk a bit about the advanced directives, but the focus here will be more on thinking about it, but I will go into the forms a little bit. So as we kind of step back a little bit, we have to think of, well, what kind of medical care would we want as we become old or near the end of our life? And we've probably all given some consideration to this, but it's nuanced because we can't think of every possible situation, and we can't just do a checklist and if this, if that, if this. And that's why it's so important to have that loved one or friend or advocate with you at the time you see the doctor, you seek the medical care, and so your wishes can be adhered to. Where do you want to be at the end of your life? Whenever I gave this talk, people would say, well, I want to be at home, but we can't all be at home, but at least a home-like environment. And I think that's important for the vast majority of Americans. Who will speak for you? And how will others know my values or wishes? And that's important because I had a fellow that came in and he really didn't want to talk about his end of life wishes. He said, my family will know what to do. Well, he had severe emphysema and he ended up on life support, and the family struggled. They really didn't know what to do. And after a month in our ICU, he was transferred to a chronic ICU where they just maintained people on ventilators, hoping and trying to wean them off. But the family struggled because they really didn't know, and he eventually had a stroke and died at this extended critical care unit, which handles this kind of patient. There are some good resources to sort this out, and these are on the web. There's a site called Prepare for Your Care. If you just Google Prepare for Your Care, it's a wonderful site with lots of forms in English and Spanish. They've got videos. They can store your directives online. There are other sources as well. The Conversation Project, again, you could just Google the Conversation Project. And this was started by Ellen Goodman, who's a Pulitzer Prize winner. Her mother had what she would call a bad death. And she decided we need to do something about this. We need to educate ourselves in the public. So this is another excellent site. And within these two sites, they've got all the state forms, pretty much everything you need. There's other very good forms. Five Wishes is a good form. End of Life Washington has good forms. But these are two that I commonly recommend. Also, I really recommend that you write an essay or a letter, or even make a checklist of what is important to you. What are your core values? Why would you want to be kept alive, and why would you want to be let go? And you could say, listen, I don't want CPR, but I might be willing, if I had a pneumonia, to be on a ventilator for a week or two. But if it looks prolonged and the prognosis is not good, don't be afraid to take me off life support. This is the kind of thing that you need to talk about with your loved ones if you get to that point. These can be attached to your advanced directive forms, to your living will and your durable power of attorney. And, you know, basically the purpose of these forms is to inform your caregivers of your core values. And that, to me, why an essay adds a lot. And in my book, I do have an example of an essay that a patient handed to me that I thought was beautiful. And my wife and I have copied it and put it in our own advanced directives. So give copies to your family, certainly to your power of attorney and your regular attorney, and to your healthcare team. And most healthcare institutions now can copy these into electronic medical records, and a number of them can make your directives available 24/7 electronically. So we are making progress. We don't have a statewide registry for these like Oregon does. If you call 911, they can pull up your pulse form electronically as they arrive at your home. We don't have that in the state of Washington. There was a try at one point, but the tax dollars got pulled. It's something else that it might be an interesting thing for WACCRA to work on, actually. So make sure these documents you have can be found in a crisis. So about a year ago, I happened to be in an apartment not too long after a woman had fallen and broken her hip. And she was kind of yelling at her husband as to where to find her insurance forms and where the pulse form was. And you know, it was just not a good situation because she was in pain and her husband really didn't know where these could be found. I'll tell you what we do at Skyline, and I think this is done differently depending on your institution, but I would strongly suggest that you standardize it for your institution so these documents can be found 24/7. And what we do is actually put them in a Velcro removable plastic, clear plastic hanging folder that can be put under actually it's standard now in our building. It's inside the kitchen sink cabinet. Most people don't want it up on a refrigerator and have to look at it every day. Some people will put it on the back of the bedroom door, but we've standardized for the building. So 911, when they come here, they can find a pulse. But I also recommend you put in a list of your medication, all your insurance information, and also your regular advanced directives, particularly who your power of attorney is. This folder can just be pulled off the Velcro, put on top of your gurney, and go to the emergency room with you. And believe me, 911 loves this. They do not want to do an intervention that you don't want. They call it medical last rites, where they have to go in and do CPR on somebody that's obviously near death. So what is your acceptable quality of life? And this is going to be different for each one of us. It depends on your background, your religion, your spiritual focus, your tolerance of disability. I ran into a couple down in California when I gave this talk. They're both 60 and good health, but they both had do not resuscitate bracelets on their wrists. And I said, you know, you guys, you're pretty young. You really want that? She said, oh yeah, we've seen CPR. We would never want that. If our heart stops, let us go. So everybody looks at this a little differently. But what makes life worth living for you? And some people might say it's an anniversary, it's a birth of a grandchild, it's a wedding. And some people will do pretty extraordinary things to hang on to get to that. I did, and I write about this in the book, a high school senior at one of the local high schools had severe cystic fibrosis. I had been following her for several years and sharing her care with the University of Washington Cystic Fibrosis Clinic. And she was getting near the end, but still functioning. She still wanted very badly to become a nurse, and she was excelling in so many ways, except her body was wearing out. She had liver problems, bleeding from esophageal veins, and weight loss, and of course, severe lung function. But her goal in life was to go to the senior prom. And she was going to do that no matter what. Her mother was quite worried. Her boyfriend said, you know, it's okay, we don't have to go. But she said, no, yeah, I want to go to my senior prom. And she did, but not too long after that, she ended up having an acute crisis. 911 was called, and she was taken to a community hospital and put on life support, transferred back to our hospital. And my colleague from the University of Washington came over, and we sat with her and her mom. And it was a sad situation because she was never going to make it off the ventilator. And mom knew that, but her birthday was the next day. And so we kept her going another day and took her off life support the following day. But her mother, through her tears, said, at least my daughter got to the most important event of her short life. She was able to get there. So each of us has our own feelings about this. What are the most important things for you to achieve given your level of function and your illness? And what are your biggest hopes and what are your biggest fears? And I would love to take a break here and ask each of you about this, but maybe when the COVID clears and we can speak live, I would be more than happy to try to come to your facility and try to talk with people live. So I was interviewed several years ago by Katie Sewell on KUOW. We actually had about a series of 4 or 5 interviews about end-of-life issues. But her first question to me, I was a little unprepared for this, is what's a good death, Dr. deMaine? And I kind of hemmed and hawed, and then I said, well, you know, when your wishes are adhered to, that to me would be a good death. So these are some of the things that I've come up with from looking at the literature and talking to patients. I think we all want pain and symptom management at the end. And we're not talking about so much death, we're talking about a good dying process. You know, death is something that is still mysterious and an unknown new adventure we'll all be taking. But it's the dying, I think, that concerns us. I have patients tell me, I'm not afraid of death, it's the getting there that is the bothersome part. We want our wishes honored. We want time for preparation, both spiritual and natural. We want a sense of completion of goals. And a number of people want a sense of a legacy, having contributed to others, even if it's just within your own family, to leave some positive things behind. And we want to be at peace, surrounded by loved ones. Those are all key factors. The causes of death, interestingly, the slide isn't too different from 2013 now. We've seen falls in death rates from breast cancer, prostate, stroke, and certainly HIV. 911 is finding that their number of heart attacks that are going down is actually falling. 911 is doing a whole bunch of other things. But notice the big bar here, Alzheimer's. As we age, our risk of Alzheimer's goes up. And this is the very common fear that we all have, is when we hit age 90, about a third of us are going to face some degree of dementia. Now, what's going on with COVID? Well, you can see that heart disease, this is heart disease and cancer going along around 13,000 deaths per week. And this is COVID starting early 2020 down here, and then spiking, and then we thought it was getting under control. And here, this graph really should go up almost off the top, because now we're getting at least 3,000 deaths per day. So that'd be up to 21,000, just extending this red line up. It just shows how COVID-19 is now the leading cause of death. And who would have thought that we would be facing something like this? This is from the humor magazine, The Onion, just reminding us that world mortality remains at 100%, kind of reminding us that we're not going to get out of this alive. I've not updated that slide. I think it's going to remain the same. Somebody asked a philosopher how he would like to die, and he said, when I least expect it. That would be nice. You're here 1 minute, gone the next, and not hard on you at all, but it's certainly hard on people around you. But really, less than 1% or just a few percent of us have this sudden death. Most of us have a more intermittent thing, a decline with cancer, Alzheimer's, or if you have heart disease or lung disease. It kind of goes like this. We start at a certain level of function, and over time, there's little flare-ups of whatever we have, or maybe an added condition. And then we get down here, and then something always happens at the end. And one of my favorite books, and a lot of you no doubt read it, is Togarundi's book called Being Mortal. And he talks about this difficulty here. It's called letting go, how difficult it is to say, okay, this time I'm going to shift gears. I'm going to quit not quit, but dial back on intervention, and perhaps go for comfort care, go into hospice, and we'll talk about that a little bit more. This is a very difficult thing for doctors to let go, for families to let go, and often individuals. It's a kind of an existential shift in our thinking that occurs at that inflection. So as we age, we get at some point become very sick, and then we have to think about our options. There's really three pathways. One is saying, hey, I want everything. And certainly for young people that are healthy, older people, they might say, yeah, I want everything. I want CPR, I want a ventilator. Some might say, well, don't want CPR. If my heart stops, let me go. But if I get pneumonia, I might take a ventilator for a week or two. But if it looks like I'll never get off, please remove the ventilator and let me go. There is selective medical care, and this gets difficult. If you've had a paralyzing stroke and things don't look good, would you want food and nutrition given if you're unable to cope with this on your own? Particularly feeding tubes. Would you want a feeding tube or wouldn't you? And this is a difficult situation, and sometimes the tube is put in before you're aware. My dear sister I read about in the book had a massive stroke in Pennsylvania and was taken to a hospital. And before they found her advanced directives, they managed to put in a feeding tube, what they call a PEG tube, that goes right in through the abdominal wall. And once the tube is in, it's always not a little, but it can be quite difficult to have that conversation about removing the tube or not using it. And this caused the family a lot of consternation, but ultimately they decided to stop feeding and use hospice, and she was treated at home, not without a lot of difficulty. And then the third choice, and this is common in hospice certainly, is you want care for comfort. And we'll talk a little bit more about comfort care. So how about CPR? Would we want CPR? Cardiopulmonary resuscitation. Well, the survival rate, if you look on television, is about 66%. And you know, people go into the ER, they go into cardiac arrest, they get shocked, and they walk out looking pretty good. It can happen, particularly in the state of Washington, where we've had wonderful medic training, but it's nowhere as good as this. In real life, if you look at the overall population for sudden cardiac arrest, you're not doing badly if you can rescue 15 out of 100 people. If you look at the frail elderly, and at my age 82, I think I'm getting into that frail elderly population, less than 5 out of 100% out of 100 people will survive. And then for advanced chronic disease with cancer and other things, advanced heart disease, only 1 out of 100 people will make it through. And then often these people end up in a nursing unit and not very well off. Now, there is an exception to this. If you are in good health and let's say you're 60 years old, you have a sudden heart attack, the medics get right there, you have what they call a shockable rhythm, they can get you to a trauma center, a very good ER promptly after defibrillating your heart. The Heart Review has, and the UW have reported as high as 50% survival in patients like that. But many of us that are living on CCRCs, that would be an amazing outcome. But I don't think any of us are the healthy 60-year-olds that were in that study. Artificial fluids and nutrition. When we're unable to eat or drink normally, fluids and nutrition can be used. When my father was 93, he was aging, he was in an assisted nursing unit, getting very good care in Western Pennsylvania, but he quit eating. And my sister got really worried and talked to the doctor, and they ordered a whole body CAT scan. And they didn't find anything except a 1 centimeter tiny little spot on one of his kidneys. And my sister said, shouldn't it be biopsied? And I said, no, Pat, it can't be relating to any of this, because even if it is a small cancer, it's not symptomatic. So he had always said that he didn't want to be kept alive artificially. So we did not put in a feeding tube, and we did not give fluids. So he elected to withhold the fluids. He died what I would call a very natural death. I was able to be on a cot in his room in his wonderful nursing home in Western Pennsylvania. And he went the way I think a lot of us would like to go, with family around, music on, we were playing bridge in the room, and Dad died peacefully. So in dementia, there's been pretty clear literature now that tube feeding is contraindicated for dementia patients. They actually do worse with tube feeding. Just careful spoon feeding is the way to go. But loss of ability to swallow and digest food as part of end-stage dementia is quite common. So how about antibiotics? There was an internist in town that actually surveyed doctors with patients in nursing homes that were, let's say, gave a scenario of a patient with advanced dementia, hadn't recognized their family in years, hadn't been out in bed much, and suddenly became very ill at night with 104 fever and dropping blood pressure, probably urinary infection turning into sepsis, a bloodstream infection. Would you give an antibiotic? And 80% of the doctors, and this is way back when, said, if I know the patient family, I would not give an antibiotic. So sometimes we don't want to just knee-jerk give an antibiotic. Sometimes pneumonia used to be the old man's friend, but sometimes other infections can be also. So but on the other hand, let's say if a cancer patient on hospice gets a painful infection that an antibiotic might help, of course give an antibiotic, because the goal is for comfort. So comfort care is something I was never taught about in medical school, but it's very important because we're trying to improve the quality of life. We're trying to focus on the patient in a holistic way, and also care for the caregivers. And this is where we'll get into a little bit, hospice and palliative care comes in. But the healthcare decisions are made not to treat an organ or to treat a specific diagnosis, but it's to control symptoms. Is there nausea? Is there pain? Is there spiritual crisis? Is there depression? You know, what do we need to focus on? So both palliative care and hospice can help along that score. but never let a doctor tell you there's nothing more we can do. No, I really would get all over physicians if I ever heard them say that to a patient. There may not be a specific drug that we can use, but it never means no care. We can always provide care. We can always say, try this or try that, but let me know how you're doing, or come back and see me again. So we don't want to try to draw a line there where we're kind of withdrawing care. And care is always possible, even if cure is not. So I'm sure you're all familiar with hospice. It's a wonderful service, pain and symptom management. Medications and medical supplies are covered, specialized nursing, care, extended care like social services, volunteer services, training caregivers, and counseling and bereavement support. And but as we know, hospice isn't a place, it's a program that's conducted in your own home or living situation. And we're fortunate in the Seattle area to have a number of good hospices and good, I know a few, the medical directors, and they're really pretty well-run programs. I do have a thing in a book that says, think, for anybody that's really ill, think hospice and think about it early. Have an interview with hospice, talk to them about what they offer, talk to them about what it means. It does not mean giving up. In fact, there is some data that people that get into hospice early live longer than people that don't get into hospice, particularly talking about cancer patients. So of course it is covered by Medicare, and most other insurances now cover it also. So what's palliative care? Didn't exist when I was in training or in medical school, but it's a fairly new specialty. University of Washington has can be a Center for Excellence, a wonderful palliative care training program. Their focus is not just on hospice, but it can be at any age. And they tend to focus on an individual to improve their quality of life. They can coordinate care teams if the care plan is confusing. You may be seen by multiple specialists. You got the kidney doctor, the heart doctor, the lung doctor. You're confused about what the plan is. So you can ask for a palliative care consultation, particularly in the hospital, and they can help sort things out. So their focus is on relieving symptoms and controlling pain, providing guidance among the specialists that are taking care of you, and to pay attention not just to you, but to your caregivers and your families. Often in these talks, I leave out the caregivers, but caregivers are extremely important, not just during the life while you're alive, but supporting them after someone dies. And the caregiver support group, both before and after, are so important. And I would imagine that your CCRCs have something like that. So unfortunately, we talked about hospice, but it tends to be delayed in about half the patients. And some people hospice isn't called in until the last day of life, and that's way too late. We're getting better at that. And actually the USA leads Europe in allowing cancer patients to die at home. But that's the glass half full, but the glass half empty is we also lead in overuse of technology in the ICU near life's end. We're still not good about saying, I think really being honest with patients and families about the limitations of what we can do with more technology. So who will speak for you if you can't speak for yourself? This is a short video I'd like to show you, and then I'll be right back.
Be your healthcare proxy? Like if you need someone to tell the doctor what to? I just go with whatever the doctors say. I wouldn't want to bother them. They're so busy. Doctors know best, right?
Be your healthcare proxy? Sure, I'd be happy to. If I'm in town, check out my Instagram pics from Peru. Wish you were here.
Oh, I could never let you go. I can't even throw a plant away. As long as it's got one little green leaf. I'd be like, can't we upload her to the cloud?
Well, heck yeah. I've given this a lot of thought. Let me tell you what decisions you're best off going with. You never let them resuscitate you. And if they even try to hook you up to one of those breathing machines, never. I got this. I totally got this.
How can you even talk about this? I can't, okay? I just can't. Mom, it's not like you're gonna die. No, I can't talk right now.
Oh wait, did I show you that meme from iFunny? The cat and the dishwasher? Oh my gosh, okay. So the cat's like, bleh. And then he's like, wah! Oh wait, sorry, what?
Well, hon, you and I have been through so much together. Here's what we'll do. We'll sit down, we'll get a cup of coffee, and you tell me what matters to you.
Well, it wouldn't be easy. I mean, I'd be sad, but I'd have your back.
I remember when we went through this with Mom, we really spoke for her. So I think I can do that for you. Let's talk about what you would want.
So that was a video that I had downloaded from the Conversation Project, one of the websites that I mentioned. So the question is, who is the best person for the job? And it's got to be somebody close to your heart that can stick up for you, even push back against what the doctors are saying, and also be able to reflect your wishes, even though it might not be theirs, and that's hard to do. But they've got to be available and ideally be at the bedside when we're having the discussions. So that's something to think about. Occasionally, I have somebody say, "Listen, I don't have anybody. I don't have a friend. I don't have anybody I can lean on. Is there any other service available?" And there is. In Seattle, and I think they're going national and statewide. It's called the Washington State Healthcare Advocacy Association, or WACCRA. And by the way, this video I will put up on my blog, and I'll give you the blog address and the slides. And if anybody wants that, they can contact Rick, and I can send them the slides and the video talk that we're doing right now. I send that to them using an email mechanism to do that. But anyway, let's say, what does Washington say about who should be our advocate, who qualifies? Well, of course, if you have a court-appointed legal guardian, that person supersedes. But the main document is this durable power of attorney for healthcare. We call them advocates, but this is the legal name. But let's say if we don't have that, who speaks for us? Well, it's your spouse or registered domestic partner. Now, a number of people don't have spouses, so this then goes to the adult children. The bugaboo in our law is that the children all have to be in agreement. So if one of your 4 kids, let's say, disagrees with the plan to remove a ventilator or do an operation or whatever we need to do, then we can't go ahead. So it's very important if you say, well, all my kids will decide together, they better get along. Better yet, choose one and make another an alternate, or you can have 2 together to keep peace in the family. But just remember, the more people that are authorized, the more difficult it can become. I would usually, in a family conference, though, try to get everybody involved. I would get speaker phones, cell phones, any way people can Skype in on a conference and try to include everybody, because if somebody feels excluded in the decision making, they can become very obstructive and very angry. And if they have an alcohol or drug problem, then it really becomes very difficult. So if the kids aren't available, it's the parents, then it goes to adult siblings, and then there's RCW that kind of covers this whole arena. This hardly ever comes up. I generally don't have, in the intensive care unit or making decisions, we don't usually have to pull paper out of the chart and go over this kind of thing in detail. Usually it's pretty clear. People have the papers or the spouse is there, and we go ahead with on-the-spot decision making. So I'll just touch on this very briefly because this is not an advanced care issue. The death with dignity law comes up at a time when we are approaching death, and we want to know what the Washington law is, and we want to know what our options are. It's controversial. Some people are for it, some people are against it, but it did pass in our state with 59% a number of years ago. And I might say that at Skyline alone, I know of 4 people that have opted for death with dignity. They were all handled well. It was permitted by the institution because it's within the state law, and I think there was good support. So anyway, for somebody to opt for this, they have to be terminally ill, certified by two physicians. They need to be competent to make the request. Mental health consultation can be requested. And no surrogate or durable power of attorney can make the request. And no one can give the meds to the patient. They need to be self-administered. And there's a waiting period involved. And a number of people will get the medications and then never take them. But they want to have that right. And I think a lot of this is the concept of people want to have the right to invoke this law. But in reality, only about 1 in 300 deaths in Washington state are due to the implementation of the DWD law. So it is there, it's important to some people, and where I've seen it, I've not been involved directly in any of this, but where I've seen it applied, it has been handled well. In fact, there was one family of a woman that implemented this. She was very elderly, had an end stage blood disorder, said, I'm ready to go. All my contemporaries are gone. I don't want to, I know I'm not going to live much longer. And her family was totally supportive. In fact, they came back and had a presentation about their feelings about her choices. So they were quite open about it. More commonly, it's much quieter. Another option we have toward the end of the life, and this is called VSED, or voluntary stopping eating and drinking. And there was a conference about this, actually a international conference at Seattle University School of Law back in 2016. And this is a legal right we all have. We can all stop eating and drinking. It's difficult to do medically, but some people that are descending into dementia don't want to go there and decide to invoke this option. They need support of family and physician and loved ones. But Diane Rim, who was featured at Town Hall a couple of times, written a book called My Own Way. And Phyllis Schachter in Bellingham has written a book about her husband's descent into dementia, a brilliant scientist, but went that route, and her supporting him and the help they got from their physician. But because none of these people that do the VSED route would qualify for the death with dignity route. So this is another option at the end. Not that frequent, but it's something that people need to know about. So how about forms you need to fill out? Well, I mentioned durable power of attorney for healthcare, the living will, and of course the post form. Probably a lot of you have post forms, the bright green form. I call it the 911 form. The medics love to see this because they'll know whether to start CPR, know whether to transport you to the hospital, and basically it's an outline of your wishes. If you don't have one, I'd certainly talk to your doctor, particularly if you don't want certain interventions. If you want everything done, you don't need a form because you're going to have everything done. So it is honored by 911 responders. It goes from your home to medical facilities, and it's signed by you and your physician. Very unusual form. It makes it a legal standing medical orders. Not just physicians can sign it, but your PA or nurse practitioner can sign it. Now, there is another newer directive called the Dementia Directive that was developed by Dr. Brock Gassner at the UW. And it's called, if you just type in Dementia Directive, you'll find it listed as dementiadirective.org. And it allows you to say what your choices would be in early dementia, moderate, or severe dementia, because your choices may vary depending on how impaired you are. So it's something you should know about and think about. Compassion Choices Now, End of Life Washington also has a dementia directive, which is much more complete in a way, but it's much longer and somewhat daunting for people to fill out. So I think this one, the Dementia Directive, has become more popular. Now, what are the issues with advanced directives? Well, they can be problems in finding them, and times may not be followed. That's always a concern. They need to be updated with a change in your health, and they can't cover all situations. So that's where your advocate again comes in. Another thing some people consider doing that have a pulse form that says do not resuscitate, they will get a bracelet or a medallion that says do not resuscitate. But we don't have Washington state law at this point, unfortunately. California does. You can get a certified bracelet that Medic One will follow. Here, Medic One may honor a bracelet or medallion, but you can't be sure. Maybe that's something else WACCRA can work on. Now, I'm nearing the end here. I'm sorry I'm running a little long, and I certainly hope I have time for questions, but your conversations with your advocate should be ongoing. This is not just a one-time thing. Your health may change, certainly every 10 years. A change in your living situation, a death of a spouse, or anything that's gone on like that. Rethink these things. If you want to read more books, I did mention Tograndi's book, Be Mortal. There are 10 top books listed on the conversationproject.org. You can find this talk on my blog. It's called endoflifeblog.com. And as I mentioned, my book, this is the book that came out in December through Clyde Hill Publishing. I'd like to thank them and my publisher for at least believing in me to get the book out. It's been quite a challenge, but a lot of fun to do this. So I'm going to stop here, and I hope there's some questions that have been coming in.
We do have one, Jim. A person wrote in, if someone is quite ill and wants to die using morphine for comfort, etc., does the senior management of a CCRC have the right to say no and require the resident to go to skilled nursing area and not remain in his or her apartment with their own hospice team?
Well, you know what goes on in Las Vegas stays in Las Vegas. Kind of, you know, if you're in independent living and you're in your own department, you're in an unlicensed facility. So you know, and hospice has a lot of leeway. I didn't get a chance to talk about the double effect that had with Larry. The intent with Larry was not to kill Larry. The intent was to relieve his suffering. The effect, it's kind of a double effect, was that, yeah, it did speed up his death a bit, but it's legal, it's accepted by medical specialties, it's been tested in court. So I suppose a facility can try to do anything with their own internal rules, but I think there's pretty good pushback. Now, if you're using an intravenous medication with the intent for death with dignity, with the intent to just, you know, end their suffering completely, that is not legal in the state of Washington, and it certainly could be challenged by a facility if that was the intent. So it's a little. Some people think that's you know, just Mickey Mouse to do that. but I think it's important in the law that we look at the intent of what you're doing, and very unlikely to be challenged on that as long as the family's on board. We have one story in the book called Doctor, You Killed My Mother. And it was the lady that I did give morphine to, and he misinterpreted it. He thought I purposely killed her. And so it took quite a conversation to bring him around. So transparency, letting your intent be known, those are the critical things.
Here's another question for you, Jim. Most of Seattle hospitals are now controlled by the Catholics who oppose end-of-life measures, as I understand it. What are we to do?
This is a concern that I share, particularly with big beginning of life issues. I think the obstetricians and gynecologists are facing a lot more issues there. Death with dignity laws is almost always in a home environment or nursing home. I don't know. I don't know of a single case. I'm sure they're out there where it was done in a hospital setting. But in terms of my critical care colleagues that I talked to, for example, at Providence, Swedish, and I guess Virginia Mason now is going that route also in Seattle, they say that they don't feel restricted in removing life support. And I think the Catholic Church is, they accept, that you are not forced to keep somebody on life support that is already on life support. So they don't feel particularly restricted. But we'll see over time how that plays out. But to me, the beginning of life issues are more concerning. And I know some patients have switched providers. I know End of Life Washington is certainly concerned with the death with dignity future, any restrictions that they're concerned about. But where I've seen the death with dignity applied, it's almost always been in a home or home-like environment. Our neighbors to the north up in Canada have expanded their law. They feel you have a right to die, and the doctor is allowed to give intravenous medication at the bedside. But we don't have those kind of laws here.
Here's another question. What kind of comfort measures can be done for VSED?
Voluntary stopping eating and drinking. Usually it's sedatives, the usual relaxing kind of medications, low dose narcotic, but they usually will get and good mouth care with swabs, mouth moisturizers, but I think it's a little different for each person. And talking to Diane Rehm, it's difficult. But I think having a caring physician who is willing to prescribe, the benzodiazepines like lorazepam, Valium, and then some low-dose narcotics, and again, good mouth care. But it's tough. They get to a certain point where they slip into coma, and then it's not too bad. But it can take 6, 7, 8, 9 days for death to occur that way.
Here's one other question. Hoag Hospital in Newport Beach, California is cutting relations with Providence Health after 1 year of merger. Hoag is suing Providence for not supporting birth control payments.
Yeah, I think, again, you get into the beginning of life issues, birth control. Can you abort a child in certain situations? Those kind of situations, I think it's going to be very hard on that OBGYN community and in primary care too, their prescribing habits.
Well, that's the end of the comments and questions. I want to thank you, Jim, for being willing to give this lecture, and really appreciate it.
Okay, well, I so wish that I could put everybody on a microphone and we could be chatting, but hopefully if Dr. Fauci is right, as 2021 progresses, we'll quit talking about COVID every day and talk about happier things. I will try to make this recording available. I do have the Dropbox. I certainly can send slides. So if you have other people in your CCRCs, I'm more than willing to have you share that.
Well, thank you all for joining, and hope you all are enjoying getting your vaccines, and hopefully we can break out of here pretty soon.
Yeah, for sure.
And have a little bit different life than we've had here for the past few months. Begin to see each other face to face again. So you all take care, stay healthy, and we only have a few more weeks before the vaccine kicks in. So at least our communities might be able to loosen up a little bit. Who knows?
Okay, wonderful. Thanks so
Thank you
much.
all.
Okay, good night, everybody. So Rick, I think when I close this, it'll automatically convert it to an MP4 format. And so I'll try to make that available.
Okay. Yeah, we had a couple of requests to have it on your blog so we can just send out the link.
Yeah. Okay, take care.
Okay. Take care, everyone.
Bye, everyone.